So the topic for today is heart failure management, a holistic approach. Now, before initiating our discussion on Sacubitril Valsartan, I'll briefly give you an overview of heart failure. The global statistics of heart failure are horrifying, as you can see on this slide. When we look at the Indian figures, we have at least 8 to 10 million patients of heart failure in India. What is very distressing is we have a lot of young population of heart failure. About 22% are below the age of 30 years, and a major chunk is contributed by diabetics, almost to the tune of 54%. The mortality post-admission is very high, 20 to 30%, and medication adherence is only 25 to 50%. Now, what is very important to realize is that heart failure, once sets in, runs a malignant progression with a very high mortality. The 5-year mortality is almost to the tune of 50%, a figure higher than most of the malignant lesions. What is also very important to realize is that myocardial apoptosis continues unabated, and this is evidenced by chronic mild elevation of troponins in the blood. And this does not produce symptoms and may result in deterioration of the condition of the patient, and he may get admitted with hospital for heart failure. If we look at the statistics, 1 in 4 patients of heart failure reduced ejection fraction with mild symptoms die or is hospitalized within 3 years. 1 in 4 patients of heart failure with reduced ejection fraction, the first manifestation is worsening of heart failure or sudden cardiac death. And all of us know heart failure has a lot of arrhythmogenic potential, and sudden cardiac death is more common in mild heart failure. For example, in class 2, 66% of patients died, while as heart failure progresses, it is heart failure which results in death rather than sudden cardiac death. So what is very, very important to remember is that chronic heart failure is never stable, and this is a great myth. As I pointed out right at the beginning, that heart failure, once sets in, runs a malignant progression, which means you have to take all therapeutic measures at the earliest and continue them vigorously if you want to improve the outcome of the patients. And pharmacotherapy can blunt this malignant progression, as we'll see in a couple of minutes. Other thing which is very important to remember is every hospitalization, every rehospitalization takes the patient closer to death, besides imposing a lot of financial burden on the family, on the country. So if you are able to minimize or prevent hospitalization for heart failure, this is indeed a great achievement. Now, when we look at the evolution of therapies in heart failure, we have the pre-Sacubitril Valsartan era, 80s, only digoxin and diuretics were available, and the treatment was mainly non-pharmacological. Pre-80s. 80s was a hemodynamic decade, and we had vasodilators and inotropes. 19s, hero hormonal decade, we had RAS blockers and beta blockers. And 2000 was a device era. We have lots of devices, ICD, CRT, LVAD, and so on. In 2010 onwards, we had the cellular era, cell therapy and gene therapy. If you look at the history from 2003 to 2013, no mortality reducing drug appeared on the scenario, but 2014 initiated dawn of a new era, that is the Sacubitril Valsartan era. During this 2014, the paradigm HF trial was presented, and this was in chronic stable heart failure. In 2019, we have the Pioneer HF trial, which is in acute decongestive heart failure. So ARNI or Sacubitril Valsartan initiated dawn of a new era. And this is the scenario prior to the Sacubitril Valsartan era. We had wonderful drugs, ACEI, which decreased mortality by 16%, beta blockers 34%, MRAs 30%, ARBs 17%, and ivabradine, which decreased heart failure mortality 19%. But despite all these mortality-reducing drugs, the mortality in heart failure was still substantial, and the necessity of heart failure. Now, this shows the evolution of ARNI. 2016, Sacubitril Valsartan was approved for clinical use after the paradigm HF trial in ambulatory patients with heart failure reduced ejection fraction. 2016, we had the titration trial, which tried to assess the safety and tolerability. It had slow and fast up titration of ARNI in ambulatory patients with heart failure. In 2018, we had the transition trial, which tried to assess the safety and tolerability of pre and post discharge initiation of ARNI so that you can use in acute decongestive heart failure. And 2019 was the era of Pioneer HF trial, which established the use of ARNI in acute decongestive heart failure after hemodynamic stability. ARNI is a wonderful drug, and it has many first to its credit, which is not seen with most of the drugs. The first to its credit is it has evoked a new concept of multi-system neurohormonal modulation, never heard before, never practiced before. The second first to the credit of ARNI is it came as a class 1 recommendation to replace a class 1 drug, that is ACE or ARB. And it never happens, very rarely, that a class 1 drug is replacing another class 1 drug. Usually when a new drug is approved, it is usually as an add-on therapy and not as a class 1 indication to replace a class 1 drug. So this is unique feature of this wonderful drug. And lastly, it has shown a 20% reduction in cardiovascular death and hospitalization for heart failure on top of all guideline-based medical therapy. Now, this is how it acts. Now, in heart failure, two systems get activated. One, there is neurohormonal activation of the RAS and the sympathetic system, and the activation of RAS, as you can see in this slide, increasing levels of angiotensin II produces ravages on the cardiovascular system. The other system is the natriuretic peptide system, which is a protective system, but in heart failure, it does not play a very dominant role because all the hormones of the natriuretic peptide system, they are rapidly metabolized by the enzyme neprilysin. The neprilysin inhibitor sacubitril, when it is added to valsartan, targets both these systems. Valsartan blocks the AT1 receptors and prevents the patient from ravages of increased levels of angiotensin II, and the neprilysin inhibitor sacubitril inhibits neprilysin enzyme so that the natriuretic peptides can act for a much longer time. This is the basis of the action of sacubitril neprilysin inhibitor. Now, first we will talk about the chronic heart failure with reduced ejection fraction. What are the benefits and what are the achievements? Now, these are the results of the paradigm HF trial. As you can see on the slide, it showed a 20% risk reduction in the primary endpoint of cardiovascular death and first heart failure hospitalization on top of all guideline recommended therapy. Individually, if we look at the primary endpoint, there was a 20% reduction in cardiovascular death and a 21% reduction in hospitalization for heart failure. There was a 20% risk reduction in sudden cardiac death, 16% reduction in death from any cause, that is all-cause mortality, 23% reduction in admission for heart failure, and if the patients are admitted, 18% fewer days in the intensive care. So they've had a panoply of benefits. What about acute decompensated heart failure? Initially, we had the transition trial and the pioneer HF trial. And this is the transitional trial, that is initiation of Sacubitril Valsartan in hospitalized patients of heart failure reduced death and fraction after hemodynamic stabilization. The primary endpoint of this trial was to see whether we can initiate Sacubitril Valsartan in hospitalized patients after hemodynamic stabilization. So the primary endpoint was to evaluate the proportion of patients achieving the target dose of Sacubitril Valsartan 200 mg BID at week 10 post-randomization in the pre and post-discharge group. And the secondary objectives were many, like achieved and maintain the dose of Sacubitril Valsartan 100 mg or 200 mg BID for at least 2 weeks leading to week 10 after immunization. And the other endpoint was achieved and maintained any dose of Sacubitril Valsartan for at least 2 weeks leading to week 10 after randomization. And how many patients permanently discontinued this medication due to adverse side effects. And the results showed that pre or post-discharge initiation of ARNI was very well tolerated. 50% of heart failure reduced ejection patients after stabilization, after this episode, tolerated ARNI, the maximum dose 200 mg. 86% of the patients stabilized, tolerated any dose of ARNI, and the discontinuation rate due to side effects was negligible. So the transition trial showed that initiation of Sacubitril Valsartan in a wide range of heart failure reduced ejection patients early after ADHF, after hemodynamic stabilization, this drug can be initiated in the hospital or shortly after discharge and is feasible and overall very well tolerated. And this led to the pioneer HF trial. This trial was carried out in patients with acute decongestive heart failure. It has a 12 weeks duration, 8 weeks was a blinded randomized study, and 4 weeks was an open extension period. And ARNI or Sacubitril Valsartan was compared head-to-head after hemodynamic stabilization. By hemodynamic stabilization mean we should achieve at least a systolic blood pressure of 100 millimeters for preceding 6 hours. There should be no increase in the dose of IV diuretics, no use of IV vasodilator during the preceding 6 hours, and no use of IV inotrope during the preceding 24 hours. And the primary endpoint was time average proportion change in NT-proBNP from baseline. And the secondary endpoint was change in NT-proBNP at week 8, NP system activation, that is the ratio between BNP NT-proBNP ratio and the CPMP, cardiac fibrosis remodeling assessed by soluble ST2, and tissue perfusion or injury by troponin I sensitivity. And this shows the results. As you can see, 29% reduction in NT-proBNP with Sacubitril Valsartan, as you can see on the left-hand side, compared to enalapril, and a 46% reduction in the serious events composite, as you can see on the right side, that is the risk of death, HF hospitalization, LVAD implantation, or risk for cardiac transplant. Interestingly, there was no worsening of renal function, hyperkalemia, hypotension, or angioedema. It means the drug was very well tolerated. And after 8 weeks, we had an open extension study for 4 weeks, which tried to shift patients who were on enalapril to sacubitril valsartan, and this showed that when the patient was shifted from 8 to 12 weeks enalapril group to sacubitril valsartan, you can see a 35% reduction in NT-proBNP concentration after switching from enalapril to sacubitril valsartan within 4 weeks, clearly indicating, if possible and feasible, try to initiate this therapy right after hemodynamic stimulation. And when we look at this serious clinical composite, again you can see a 33% reduction in serious clinical composite outcome with sacubitril valsartan compared with enalapril. And this shows the secondary analysis of the first 8 weeks. You can see a 45% reduction in time to first HF readmission with the initiation of in-hospital sacubitril valsartan. The evidence clearly points out, if feasible and possible, try to initiate this drug before discharge when the patient is admitted. And the drug has been recommended by the guidelines. This is the ESC consensus recommendation that initiation of sacubitril valsartan rather than ACI or ARB may be considered for patients hospitalized with new onset heart failure or decompensated heart failure to reduce the short-term risk of adverse events and to simplify the management by avoiding the need to titrate ACI first and then switch to sacubitril valsartan. That should be the strategy, and there is no need to titrate ACI first and then switch to sacubitril valsartan, and the serum markers NT-proBNP are not required. The recommendation of the parametric trial, all of us know this was a class 1B recommendation that you can initiate sacubitril valsartan as a replacement for ACE/ARB to reduce the risk of HF hospitalization and death in ambulatory patients with heart failure reduced ejection fraction who remain symptomatic despite optimal medical treatment with the conventional guide-directing drugs. And its safety is similar to ACE/ARB naive patients, and thus its initiation may be considered also in naive patients. Now, ARNI, besides these effects, it also helps in improving the remodeling of heart failure, which is seen in all patients. You can see, and we know from the data, that if you increase left ventricular end diastolic volume by 10 ml, there's a 9% increase in death or HF hospitalization. If the left ventricular end systolic volume increases by 10, death or HF hospitalization increases by 15%. Likewise, the risk of CV death and HF hospitalization increase significantly with a decrease in ejection fraction. So your ejection fraction decreases, your mortality increases. You can see in this slide the risk of CV death and chronic HF hospitalization in the CHARM study. CV death or chronic HF hospitalization increased by 45% when the ejection fraction dropped by 10%, and CV death increased by 57% with a drop in ejection by 10%. And the data from the Varsev trial also shows that if the LV ejection fraction is decreased by 20%, this is associated with a significant increase in CV death by 48% and HF hospitalization by 58%, which is statistically significant. This drug also improves cardiac remodeling by inhibiting myocardial cell death, hypertrophy, and these are the proposed mechanisms. You can see sacubitril decreases cardiomyocyte contractility, decreases cardiac myocyte death, and the valsartan decreases cardiac hypertrophy from the past and also decreases LV extracellular matrix remodeling. Pymodal treatment increased LV ejection fraction within 6 months in patients who were previously receiving OMT for 9 months. So on top of that, if you add this drug, the ejection fraction increases. The left ventricular end diastolic dimensions also decreases once you add this drug on top of all guideline-based therapy, that is beta blockers, MRAs, and others. And this drug also reduced mitral regurgitation compared to valsartan in patients with secondary functional MR, which can be assessed by the effective related orifice area, as you can see, and changes in the regurgitant volumes. And you also have a decrease in the end diastolic volume index and the left atrial volume index once you put these patients on sacubitril valsartan. And the left ventricular end diastolic dimension decreased significantly 3 months after Vimeda. As you can see, 60.58 prior to initiation of sacubitril valsartan, and it decreased to 63.15 millimeter, a decrease of 2.64 millimeter. And this is the decrease in left ventricular end systolic dimension and systolic dimension, decrease from 56.3 to 52.9, a decrease of